Hello and welcome to our discussion on provider-based physicians dealing with the cost report flow and the required documentation that's necessary during the audit. As a little agenda, we are going to be first talking about an overview of provider-based physicians. We will talk about physician costs and what is and is not allowable. We'll bring in the topics of availability versus on-call for provider-based physicians. And then we will dig into some of the cost report flow. And finally, we will wrap up with steps 5 and 6, the allocation agreement requirement, and then the supporting documentation requirements, including time studies or ER logs or the RFID badge systems. Now, as an overview, we have to understand that there are certain different types of relationships that a physician can have with hospitals. In some cases, a physician just has clinical privileges at a hospital and there's no real financial relationship. In other situations, there's more of a landlord or tenant situation where the physician has a private office on site at the hospital, but again, they are not necessarily working for the hospital. But finally, the main purpose of this training is talking about the provider-based physician relationship. In that situation, the provider-based physician is either contracting for the hospital or with the hospital, or they're employed by the hospital. So there's a little more control and integration involved there. Generally, in these situations, just the term provider-based physician or hospital-based physician, that tells you that substantially all services are provided in the hospital setting. And it's important to understand that these physicians are also getting support from the hospital because they're using either the hospital's equipment, their space, or possibly their support staff as well. So that's what generates this relationship that we're talking about through this training today. Now, again, the physician is working for the hospital, whether they are an employee of the hospital, they could be a contractor of the hospital, or possibly both. They might work as an employee of the hospital throughout the week, and then they may contract for some additional shifts. Now, we also have situations where there are recruiting companies. This especially happens in some of the critical access hospitals of the rural areas, but it could really happen anywhere. And these are recruiting companies that recruit physicians for certain shifts that are needed. Another term for this is locum tenens. This is just one of the ways, one of the options hospitals have to obtain the staffing they need. Now we're starting to dig into some of the costs here, some of the services that are provided, and of course the corresponding cost. We're eventually going to be talking about what is allowable and what is not going to be allowable, and then how we handle that. So first of all, some of the services that any physician might provide. There could be administrative services provided, teaching services, ER availability, emergency room availability. We'll talk more about that later. There's also on-call. It's another version of that, so to speak. We'll talk about why that's a service, what it provides. And right in the middle here, we have the most common or obvious one, the face-to-face patient care. The physician is actually performing some sort of service on a patient. There are autopsies that are involved here, quality management, research. There might be other services, but these are certainly the most common. So again, we're talking about services and their corresponding costs. So the questions we're going to see are what costs are incurred by the provider, first of all. And some of the answers here, we could have physician salaries. Those are the common ones. There might be costs related to the overhead from the usage of the space and equipment by the physicians. And there might also be billing costs for the physician's services. So the hospital obviously is billing for their own services to patients, but they may also take over billing responsibilities for physicians. Now, these are costs. We're not saying these are all allowable at this point, but these are costs that could be incurred, some common examples. Now, from the revenue side, when we're talking about this physician and their relationship to the hospital, the question is what revenues are going to show up on the hospital, if any. And the big question here is whether or not that physician has reassigned their billing rights to the hospital, or is the physician billing the patients on their own behalf? That's a big question that will determine how these costs are going to be treated and whether there's really any main concern when we talk about the allocation later on, whether that concern even exists. So this will come back in a little bit later. So physician costs in general. The general rule here is that physicians are reimbursed through Part B of the Medicare program, and it's on a fee schedule basis. That's just an overall general rule about physician services. Now, we also know that when any sort of service is reimbursed under fee schedule, any salary costs or really any costs related to that fee schedule item should not be on the cost report. They need to be removed from the Medicare cost report, either excluded at the beginning or removed through some sort of worksheet A8 adjustment. Now, again, that's a high-level general rule. Now, for physician costs, when we're talking about these provider-based or hospital-based physicians, they often have arrangements with the hospitals. In these cases, if they've reassigned their billing rights, the hospital may be billing Medicare Part B on behalf of the physician for that physician's services. And then the hospital is going to turn around and reimburse the physician either a salary, a fixed or variable amount, a contracted amount, whatever we talk about there. But the hospital is going to reimburse the physician for those costs. So for that reason, there are going to be costs on the hospital's cost report, and some of them relate to physician services. The question is, do we need to adjust those out, or are they allowable? That's what we're really getting at in this training. Now, if the physician does not reassign their billing rights, then the physician is billing the MAC Part B, Medicare Part B, for their own service, and none of the salary that the hospital is paying the physician could possibly relate to those professional component services. Now, what we're going to see later is that on worksheet A82, when we're making this adjustment, the whole goal is to figure out how much of that cost on the hospital's cost report relates to these services to individual patients. We'll call it the professional component at this point. How much of that salary relates to those face-to-face services that are normally supposed to be billed under fee schedule, and those amounts need to be adjusted out. However, if none of that salary that's paid by the hospital to the physician relates to those types of services because the physician themselves has already billed MAC Part B, the hospital did not, in those cases then there is no A82 adjustment needed. All of the salary that's being paid to the physician is only related to provider component services, and we'll talk about those later, that would not normally be reimbursed under fee schedule. As such, those would be allowed on the cost report. They're allowed to remain. So the big question of reassignment of billing rights, that really determines whether or not we're going to need an A82 adjustment or not. And we'll get into some of the details with this later on. So just a quick little illustration here. We have these costs that are being incurred by the hospital, and they're going to be reported on the hospital's general ledger. And ultimately, they make it to the Medicare cost report, worksheet A specifically. We'll start with worksheet A in just a bit, and then we get into A82. Now, physician costs. I said that there could be physician services to the patient. There could also be these other types of physician services that are more to the hospital as a whole. So we're going to talk about when can one of these physician services be reimbursed under the fee schedule. Because if it is fee schedule, we need to adjust that corresponding cost off of the cost report. But there are specific rules that apply before a physician can be reimbursed under fee schedule. First of all, the services have to be personally furnished for an individual beneficiary by the physician. The services also have to contribute directly to the diagnosis or treatment of that individual beneficiary's illness. Now, those services, I've thrown this term out a couple times already, but those services are known as the physician or professional component. We'll see that term on worksheet A82. We'll see it in the allocation agreement document later on. But these costs are what you might think of as true physician costs. They're the ones that are fee schedule related. We want to make sure they're adjusted off the cost report. But if the services do not meet those requirements, then they cannot be reimbursed under fee schedule, which means that either they're still allowed on the cost report, they're a provider component cost, or possibly it's non-allowable, period. That's also a category we'll talk about later. Now, as far as that professional component, it's going to show up as a cost on the hospital's trial balance, but it needs to be adjusted out of the cost report if it relates to services not normally reimbursed under Part A, which again is the provider component. That's what we're going to define here. So those services that are allowable under Medicare Part A rather than Part B, these are basically services that provide a benefit to the entire hospital, all the patients, the hospital as a whole, rather than a specific patient. Again, those are known as the provider component, sometimes the hospital component. There are a few different terms for it. Even technical component, I've heard that term. Or facility component, I'm sorry. Let's see, we have... Now, here's the other thing. These are allowed to remain on the cost report. But the question here is, what does that mean to a provider? What does that mean to reimbursement? If it's a critical access hospital that's reimbursed 101% of the reasonable cost, then that means when we allow this provider component to stay on worksheet A, not be adjusted out on worksheet A82, that's actually going to directly impact the critical access hospital's cost reimbursement. More cost equals more reimbursement. For other facility types that are paid under some sort of PPS, prospective payment system, it's not going to generally impact cost reimbursement. It might have a minor impact on some cost report flow for certain pass-through costs, but for the most part it's not, and it's just going to be used for rate setting and cost data accuracy for these types of facilities. Now, by rate setting, what I mean here is when CMS sets the DRG payments, the diagnosis-related groupings, then they're going to use cost data to determine what those rates should be down the road. So if there is more cost in several hospitals in certain areas for certain services, then that may have an impact on the DRG payments down the road, the prospective payments. So regardless of whether it has an immediate impact this year or not, it's still important to have the data reported accurately. That's always an underlying requirement. Now, the provider component costs that we're talking about are provider component services. They relate to teaching, research that's in conjunction with patient care, administration, general supervision, lab quality control, committee work, performance of autopsies, and attending conferences, things like that. These can't be billed to a specific patient's account under Part B, and so instead they're allowable as a provider component. They certainly provide a benefit to the hospital. That's the point here. Now, some things that are physician compensation. You have monetary payments. These are the most common, whether it's a salary amount, an hourly amount, a contract, a bonus. Fringe benefits, deferred compensation, vacation, retirement, things like that. Now, we also have some additional costs. Costs of physician memberships in professional societies, continuing education, malpractice, and any other item of value. We'll see some of these things reported on worksheet A82, some adjustments to the limits. But these are all physician compensation amounts. Things that are not considered physician compensation would be office space or billing and collection services or any cost related to the physician's private practice. These are not allowable physician compensation costs. They should be excluded. Now, FICA and payroll taxes are not considered fringe benefits in this case, so they should be reported as A&G with any other normal administrative and general cost. Now we're starting to talk about different ways hospitals may reimburse their physicians. I alluded to this earlier on. Now, different hospitals, obviously many of you viewing this video have your own way of reimbursing physicians. You may have a mixture of ways. There could be a simple fixed salary. That's obviously the most the simplest, I guess you could say, a fixed salary. There might be an hourly rate, which may or may not include certain premiums, certain differentials. There might also be something known as a minimum guarantee provision or an unmet guarantee. Basically what this means is we know that physicians are providing a lot of Part B type services, and either they or the hospital will bill Medicare Part B to be reimbursed for those. The problem is in certain areas, especially rural areas where the demand, the utilization might fluctuate quite a bit, a physician wouldn't generally be willing to just live with the billing revenue they get because they may be working several hours, they may have to be available several hours, and then in a particular day they may not have any Part B services come through, or maybe just a couple. Other days they may be busier. So their revenue stream would obviously fluctuate quite a bit, and that's hard for a professional to live with at that point. So they may require in their contract that there's a minimum guarantee. In other words, hey, I'll be glad to work here throughout the year or throughout the month, whatever, as long as I'm able to at least generate this much revenue. If the services don't rise up to that level, there's not a lot of demand at that point, then the hospital kicks in this additional unmet guarantee. In other words, the minimum guarantee was a certain amount, but then the actual Part B billings were less than that. Whatever that difference is the unmet guarantee. And that amount would be kicked in by the hospital as part of the reimbursement. Now, there might also be the question of what are they charging versus what the fee schedule is, including coinsurance and deductibles. We need to know those amounts to determine what was reasonable, what was allowable. There might also be variable arrangements, so there might be a billing based on a percent of charges. That's how much whatever the physician service charge was, the hospital may pay a certain percentage of that. It just depends on the situation. Again, this is just a listing of different ways that this could happen. Now, whenever we're talking about a situation where the physician has reassigned their billing rights to the hospital, and the hospital is billing Medicare for certain services, generally the entire amount that the hospital gets from Medicare does not relate to the physician services. In other words, there's some component above and beyond just what the physician service related to. This is known as a technical or facility component, and basically it means that the hospital themselves gets reimbursed for those services because they know there's an overhead factor, there's the use of the hospital space, the equipment, support employees that the physician needed to be able to do their work. So the hospital billing amount does not equate to the physician allowable amount. Generally, there's more involved with the hospital than just the physician services. So now we're starting to dig into some of the requirements and the regulations in the manual. The first part was really more of an overview. Now we're digging into what is allowable and why. So we're looking at some of the MAC rules, or Medicare rules in this case, actually, before a cost can be allowed on the cost report. We'll start with the regulation 42 CFR 415.55. And just as a summary, this basically says that the provider is incurring the cost for salary or other compensation to the physician. So there has to be a true cost incurred. The amount can't just be pulled out of thin air. There has to be proof that that cost was incurred for something related to a payment to the physician. The service cannot meet the requirements to be billed under fee schedule, because if it is something related to fee schedule, we're going to carve it out. So yes, it'll be reported on Worksheet A initially, but we're going to adjust it out through Worksheet A8 too. And we'll talk about that later on. Of course, in general, all costs have to be related to patient care and otherwise allowable, so they meet all the general rules of cost reimbursement. Now, for acute care hospitals, we do have certain limits known as RCE limits. These are reasonable compensation equivalency limits. Now, these do not apply to critical access hospitals, but again, acute care hospitals, they do apply to. And what I'm saying most importantly here, as from an audit perspective, when we're looking at this on the cost report, the most important thing is that the cost must be allocated appropriately between the professional component, which is going to be carved out of the cost report, the provider component, which will be allowed, it will remain, assuming it's reasonable, of course, and any sort of non-allowable component that has to be adjusted out through the cost report separately through Worksheet A8. Now, this, when we talk about the provider component, there might be a variety of different units or departments that are being allocated this cost, like a rural health clinic, RHC, various other departments. That's certainly fine. We'll talk more about this allocation a little bit later on and how this looks. I do want to point out some of the regulations and manual sections here, policy manual sections at the very top. 42 CFR 41560 and CMS Pub 15-1, section 2182.3. Now, as far as the next topic, we have physician availability services. We're starting to dig into some of the costs that are allowed as provider component, and physician availability is one of those costs. Now, availability, this term, when it's used, it means on-site, so the physician is on-site at the hospital, but they're in an availability status or a waiting status. Now, generally, you'd think that, hey, the physician is not actually actively providing patient care, so, hey, this seems like a cost that would not be normally allowable as a Part A cost. However, there's a specific exception in the regulations, 415.55, that allows emergency room physician availability. It's not allowed for any other department of the hospital, but it's allowed for emergency rooms. Now, technically speaking, availability is the proper term for this, but I've heard a variety of terms that hospitals use. Sometimes they call it standby or readiness. Availability is the more technical term. It's not a big deal if a different term is used, but the reason standby is not maybe the best term is that it actually has a separate meaning in the CMS regulations and policies reflecting a specific care for a specific patient. So again, it's just terminology. It's not the biggest thing in the world, but one thing that is pretty important is to not confuse availability with on-call. They are two separate and distinct things. Availability means that the physician is on site. On call means the physician is not on site. They're off site, but they will come in when needed. So one of the questions that often comes up if somebody has not really been involved with Medicare, doesn't know much about the cost report, the obvious question is, why should Medicare be reimbursing costs for services that the physician really isn't actively providing? They're not actively doing anything. They're waiting for them to be needed. Now, the main reason Medicare has historically allowed these types of costs is that hospitals are required to maintain 24-hour emergency room coverage as part of their conditions of participation. So that's a reason why the cost is needed, certainly necessary. The service is necessary, just being there. Now, physicians often get their reimbursement based on how many patients they provide services to. We talked about that earlier. So if you're in an area, like a really rural area, especially with a critical access hospital, the patient utilization may be volatile. Now, in that situation, the physician is not going to be willing to be available 24 hours, whether it's on call or in the call room in the hospital, availability status basically. They're not going to be willing to work that much or be available that much if they're only being reimbursed when a patient comes in, whatever services they provide. So instead, a hospital generally has to compensate them for just simply being available, whether on site or off site on call. Now, availability is allowed for both critical access hospitals and acutes. I do want to mention, however, on call, when we see that later on, that is only for these critical access hospitals. So that's the one distinction at this point. Availability, the on-site availability, is allowed for both critical access hospitals and acute care hospitals. Now here is an excerpt from 2109.1 talking about the availability, and it just, again, talks about the wide variations in the utilization. And because of that, the ER physicians may spend a portion of their time in availability status, so there might need to be some compensation for either those original physicians or somebody else, some other physicians, to be available when needed. Now, there are certain restrictions for the allowance of these costs. One of these requirements that must currently be met, subject to change by CMS, is that the hospital had to have explored alternative methods to see if there was some other way of staffing the emergency room as opposed to reimbursing for these availability costs. So there has to be some sort of documentation there at this point. And the other thing is that to be available, the physician has to actually be on site. They cannot be away from the facility. They cannot be on call. That's a separate thing altogether. And we talked about the unmet guarantees earlier, where if you have that minimum guarantee arrangement and then the actual physician billing does not reach that level, then that difference is going to be that unmet guarantee that what basically constitutes this cost. The other portion that the physician was already able to bill for, they've already received the reimbursement for that, and they may have even billed on their own, so that's not an issue. The issue is the hospital is kicking in this additional amount of money for the unmet guarantee. That's what we're talking about. Now, the documentation requirements, there must be a signed copy of the contract. We'll talk a lot more about the allocation agreement. That's a key thing. There has to be a permanent record of payments under agreement, a record of the time the physician was physically on site, a permanent record of all patients treated by the physician, along with any billing documentation, a schedule of the physician charges, and again, an evidence that the provider explored alternative methods for obtaining that ER coverage. So now let's shift gears and talk a little bit about on-call. Now this was brought in to the regulations in 42 CFR 41370 B4, and it's currently only found in the policy manual under the Claims Processing Manual, Publication 100-04, Chapter 3, Section 30.1.3. Now these services, these on-call costs are allowable for critical access services on or after January 1st of 2005. Now they're actually available for physicians even before that from 10/1/01 and forward, but the physician's assistants were added in a little bit later, January 1st of 2005 and on. Now obviously at this point we're well past either of those dates, but historically those were the requirements. Now ER, emergency room on-call, is the only on-call that's allowable. There are a few different requirements. They cannot also be furnishing provider services at the same time. So obviously they can't be both available and on call. They're mutually exclusive, but they can't be providing any other sort of provider services at that time. Working in the clinic, they can't be doing any sort of supervision or training or anything like that. They have to be fully available, ready to go, ready to get to the site when needed. But the other thing here that comes up is they cannot be on call at any other provider or facility at the same time. Now, in a worst case scenario, if a physician was on call at two different facilities, there's a risk that both facilities might need them at that same time, and obviously they wouldn't be able to uphold their end of the agreement with one of the facilities. So for that reason, to be Medicare reimbursable, there has to be a provision in the contract that states they are not available or they are not on call at any other sort of facility at the same time. They can only accept one on-call assignment. Now, there also has to be in the contract written information that requires the physician to come to the critical access hospital when the provider requests them to, and they must be available to arrive on site 24/7, whoever's on call at that time, within 30 minutes. Although I will say there is an extension to 60 minutes for certain areas, very, very remote times, or very, very remote areas. Here's some details on those. Now this is just an example of a contract that includes that information. And this one, it had 15 minutes there. Just talks about the shift and what services they provide. So different hospitals have different contracts. Now, what we're going to talk about here is more from the audit perspective. Now, obviously, we can't disclose any sort of audit program or desk review steps, specific ones, but these are more general things that are more obvious. When we, as a MAC, as auditors, are reviewing these physician costs, one of the first things we need to do is obtain a written contract for any sort of on-call emergency room services. We have to review the contract, and any time that the patient care was being provided. So yes, they were on call, but they actually did get called in. All of a sudden, that time now becomes direct patient care service. It's no longer on call. They're actually working with a patient. That needs to be adjusted out of the cost report because it's paid under fee schedule at that point. Any of the remainder of the time, the true on-call time, that's still allowable as a provider component. So there might be an adjustment there. Now let's shift gears and talk about non-allowable costs. Research that's not directly related to individual patient care is not allowable, so it would have to be adjusted out of worksheet A8 separately. Any sort of billing or collections activity related to a physician component service needs to be carved out, again through worksheet A8. And any sort of physician private clinic overhead would also need to be adjusted through A8. These are not allowable on the cost report, and they're not something that's going to be adjusted through worksheet A8-2 for reasons that we'll talk about in just a little bit. Now we'll start to dig into the cost report flow for provider-based physicians, and actually out of all of the cost report flow, this is one of the simplest. Basically, these costs are initially reported on worksheet A in the various cost centers wherever the physician was providing services. Now there are salaries in column 1, other costs in column 2. Not all of these costs are going to be related to physicians. Some are related to something else, other staff or other just costs in general. But whatever physician costs existed need to be a component of these costs. They should be reported within these amounts. I have highlighted a few of the cost centers that we're going to see a little bit later that report some of those. Now on A8-2, worksheet A8-2 is the adjustment detail. It's the adjustment support for this provider-based physician cost allocation. Now what you're going to see first of all in column 1 is the cost center back from that column or from that worksheet A that we just looked at. This shows us what cost center we're trying to make an adjustment to. Now CMS made a change to the cost report design in the 255210 form set from back in 2010. Now there's no longer the ability to just type in something as an identifier. Instead, you have to pull it down from this menu. Basically, they did not want PHI, protected health information to be included here, or any sort of personally identifiable information. They do not want physicians' names in here, so now they no longer allow you to type anything in. You have to identify it separately. Column 3 is the total remuneration, the total payment or compensation to the physician. This column 3 has to be part of what was already reported on worksheet A, column 1 and 2. Now again, chances are this amount is going to be less than what was reported on worksheet A for that particular cost center. It certainly cannot be more, and it generally won't be a very large portion of it because there are a lot of other things going on in the hospital. But this has to be part of what was on worksheet A. The point here is we're going to figure out how much of this needs to be adjusted out of the cost report. Now, out of column 3, there are 2 places that this could be reported. It could be reported as column 4, which is the professional component. These are the fee schedule type services that are already being reimbursed under Part B. So any amount here, like in this first one, the entire amount is reported as professional. There's nothing reported as provider component. What's going to happen here is anything that is professional component is going to be adjusted out of the cost report. Anything that's provider component will remain. Now, I do want to say something here. With the acute care hospitals, I mentioned earlier how we also have the RCE limits that come into play. For this purpose, we're ignoring that discussion. There are other other columns all the way up to column 18 that deal with the RCE limits. We're just leaving this out. For critical access hospitals, those will not apply anyways. We're focusing more on the allocation steps at this point. Now, in some cases, like Dr. B here, this total remuneration was 100% provider component. And then in other cases, it was part provider, part professional. Ultimately, whatever adjustment was determined on worksheet A8-2 would flow back to worksheet A8 under line 10, the provider-based physician adjustment. That's just the summary of that adjustment. Now, another thing to point out here, from an audit perspective, we're going to be testing a couple of different things. We're going to be making sure the transaction exists, the costs really existed, and that they were valued properly. So in these situations, we're going to need to see documentation. Depending on the scope of the review, we're going to be needing to see trial balance documentation, other more supporting and source documentation there. This is just an example. This does not tie back at all to the documentation or the numbers we just saw on the worksheet A82 or A. This is just a quick example of what that could look like. So they're breaking out ER room salaries, the physician salaries, the professional fees, things like that. But ultimately, all of those should have support ready to go in case it's requested by the auditor. And depending on the scope of auditor's review, again, we may require detailed source documentation to support any of those provider-generated summary documents. So for example, this document here is provider-generated. We may be asking for detail about certain numbers. So we may need to vouch it down to the source documentation. This could include things like invoices or checks to support dollar amounts, time studies, patient logs to support time. Next, we'll talk about the provider versus physician component. We'll break that down a little bit more. We've covered quite a bit of it. I have some citations here, the regulations, the PRM. But basically the professional component, again, that's the direct patient care services. One thing I want to add here is that the professional component also must include any sort of documentation or charting time. So it's not just patient face-to-face time, it's anything related to the recording of the services that were provided. Now, in this day and age, a lot of hospitals, many hospitals, are using electronic health records, electronic medical records, whatever, to do a lot of the updating in the room while they're face-to-face with the patient. In that situation, it might be more efficient, and there might not be separate documentation or charting time. It might be right there in the room. There needs to be some sort of evidence showing that was the situation. If there is any sort of separate documentation or charting time, this needs to be included along with the actual face-to-face time. It is part of the patient care for that individual patient. And we talked about the provider component. Basically, these are things that are allowable. They're not billable to Medicare Part B, and they are allowable to be reimbursed by Medicare Part A. We've covered those already. And we already went through this list earlier as well. So now we're going to start talking about the allocation. How do we determine how much of the cost goes to physician component, which is carved out, versus provider component, which is left in? The regulations at 42 CFR 415.60 give us the requirements for these allocations. So again, it talks about, and it points you to the definition of physician services to the provider, which is the provider component, or to the services to the patients, as well as activities that are not allowable. So those same three buckets we talked about earlier, only costs allocable to services to the provider are allowable costs. So the professional component is removed, the non-allowable component is removed, only the provider component remains. Now, there are certain situations where the costs are going to be 100% allocated to either provider component or professional component. We are going to talk about these requirements here. The first one is actually the highest risk from a Medicare program perspective. This is when there is allocation of all compensation, 100% of the compensation, to services to the provider. In other words, we're saying in this case, all of these costs are allowable because they're all provider component. There are no physician component costs. Now, at first glance, that seems a little bit unusual because it's a physician providing the service. Why do they not have any patient care services? The reason is that, first of all, the provider is certified that the compensation is solely related to provider component. And second of all, more importantly, the physician themselves bills all patient care services to Medicare Part B, and they keep their own billing. As such, any of these hospital costs we're talking about cannot possibly relate to the physician component because that's already been billed by the physician. The hospital did not bill any of that, therefore they do not need to reimburse the physician for those services. That's the situation where this could happen. Now that's D. E is the exact other approach where they're assuming that all compensation is physician component or professional component. If the provider and physician agree, if they agree to accept that 100% allocation to provide a professional component, then CMS does not require a written allocation because that's the worst case scenario anyways. If there was no written allocation agreement, as we'll see in just a bit, 100% would be reported as professional component, which is carved out. So if they agree to accept 100% professional component to begin with, then hey, there's no allocation agreement requirement. That's the most conservative to the Medicare program, therefore there's no review needed at that point. Now let's talk about that allocation agreement. This is the regulation that specifies that that allocation agreement is required. If they have these costs and they're going to be allocated to both of the components in different portions, then there has to be an allocation agreement. The provider has to submit it to the MAC. The compensation has to be reasonable in terms of time devoted to these services. And then number 2 here is the key thing. In the absence of a written allocation agreement, the MAC assumes that 100% of the physician compensation is allocated to the beneficiaries. Because remember, earlier we said if it is allocated 100% to professional component, then hey, no written allocation agreement is required. So if we do not see an allocation agreement, we assume that is what the agreement was. So basically, from a provider perspective, you need to make sure that you keep this allocation agreement. Otherwise, 100% of those costs will be disallowed, basically. Now, the next step is that the allocation agreement just by itself is not enough. There has to be supporting documentation for this. Generally, this documentation would be a time study, but there could be other situations, other things that come up. So this G, subsection G, subparagraph G, that's what brings in the supporting documentation requirements. Now the allocation agreements, the requirements that we just talked about in the regulations and policy talk about an allocation of time. It doesn't necessarily require an allocation in terms of dollar amounts. We can take the percentage of time and apply it to the total remuneration to determine how much is professional component, how much is provider component. But the key thing is this compensation has to be reasonable. It's a pretty subjective area. If there was something that looked unreasonable compared with other hospitals in the area or prior years, that's when our auditors may request more documentation from the providers. And we just talked about the 100% allocation to the professional component if there is no allocation agreement. So that would be 100% disallowed at that point. We talked about those exceptions. Now the allocation agreement itself. There is Exhibit 1 of Worksheet S-2 Part 2, which is the Hospital Reimbursement Questionnaire. Some of you may know this as the old CMS Form 339, pre-2010. But this Exhibit 1, gives a recommended format, but providers can submit their own format as long as it provides at least that same information. As we said earlier, the allocation agreement must be supported by either actual time records, time studies, or other documentation. We'll talk about ER logs in just a bit. So the record-keeping requirements, you have to maintain those time records, report it to the MAC annually, retain the physician compensation allocation, the support for total hours, and any sort of special criteria that needs to be followed for the time study option. We'll talk about a difference between physician time studies versus non-physician time studies in just a bit. Now, when we take a look at Worksheet S-2 Part 2, that hospital reimbursement questionnaire, first of all, there are two questions that relate to this that start the ball rolling. Line 34, are services furnished at the provider facility under an arrangement with provider-based physicians? If this is no, then there's no point in reviewing this. There's no documentation needed. But if this is yes, then we need to see the documentation. And then 35 just asks whether there were any new agreements with these provider-based physicians. And line 34, the instructions and the cost report talk about that as well. The middle paragraph here, allocation agreements, the Exhibit 1, are required if compensation is attributable to both professional and provider components, basically. Now, Exhibit 1. We're going to see the example of this in just a bit, but here we have the instructions for this. And it says prepare a physician time allocation for each physician by department who receives payment directly from you or a related organization. The last sentence of that paragraph is key. The physician or department head supplying this information must sign this schedule. This is a CMS requirement, and we as MACs are held to this requirement. We've received a lot of concerns from providers over the years about this signature. Either it was not signed contemporaneously or it wasn't signed by the right party. Unfortunately, we are bound by these CMS requirements as we are doing our audits. If there is no signature, if it's a signature that's well after the end of the year, it's not contemporaneous, or if it's signed by a party that's not the physician or the department head, we cannot allow this allocation agreement, and it will be treated as if no allocation agreement was submitted, which means that all the cost will be disallowed. We are bound by that requirement. Here's an example of the allocation agreement, Exhibit 1. Now, again, some of the basic information, provider name, physician name at that point, and then we get to the actual services. First of all, I guess, before we get to the services, they ask for the basis of allocation. Time study is the first option there, and they also have other. Explain what it is. It might be ER logs or it might be something else. So for each of these service types, now this is not in great detail. You could certainly provide more detail here if you want to, but line 1 shows the total hours for provider services like teaching and supervision of interns and residents. 1A is provider services related to teaching and supervision for allied health students. 1B is provider services related to non-teaching reimbursable activities, administration, supervision, all that. 1C would be specifically related to emergency room physician availability that we talked about earlier. Now there's a subtotal, 1D. These are all of the provider component services. Line 2 is physician services, reimbursable from the fee schedule. 3 is non-reimbursable at all. And then 4, of course, is the total. Now 5 and 6 are just calculating the professional component and the provider component. Now keep in mind, these don't always have to equal 100%, because there might be some that were non-reimbursable at all. So we need to have that percentage, but again, those hours have to be supported by either a time study or some other documentation. Otherwise, the allocation agreement is not really worth much if it doesn't have any support to audit it. This is the starting point. This has to be signed. It has to be dated contemporaneously, but it also has to be supported. Now, first of all, I want to go through some of the time study requirements. Again, that's the most common support for allocation agreements. First, I want to point out some requirements that are listed in Pub 15-1, Section 2313.2e. I want to specify this first paragraph, first of all. It says, periodic time studies in lieu of ongoing time reports may be used to allocate direct salary and wage costs. So the key thing there is that, the best documentation anybody would have to support an allocation of any sort would be an ongoing time report. So if there was some way to know every work day throughout the year exactly what each physician was doing, all hours of the day, of course that'd be the best documentation. Now obviously that would be quite a bit of a burden, and CMS realizes that, and as an exception they allow periodic time studies instead to try to reduce that burden. So this is an option to ongoing time reports. That doesn't mean you can't do ongoing time reports if you prefer. And we'll talk about one way that might be done with those RFID badge systems later on. But basically a periodic time study is allowable. Now the point I want to make here though, 2313.2e goes through all these different criteria that must be met in certain circumstances. Those circumstances are basically when it's not related to a physician time study. If you're talking about any sort of other staff, administrative staff, nurses, any other non-physician staff, they must meet these rather stringent requirements, including pre-approval of these time studies. This comes up quite a bit with organ acquisition, but it also relates to anything else other than physicians. But with physicians, there's a specific exception. In CMS Pub 15-1, 2182.3, it specifically says that where providers decide to employ time study techniques to substantiate either the allocation of physicians' time, we'll just leave it at that, then the provider may choose to employ the methodology described in 2313.2e, all those stringent requirements, but the provider may not be required by the MAC to utilize that specific methodology. In other words, if the provider wants to use time studies for physicians, they certainly can use those stringent requirements in 2313, but they cannot be required. The MAC cannot require that more stringent time study. We certainly can require it for all other than physicians, but we cannot require it for physicians. CMS gives them an exception to that, and basically instead of that 1 week per month requirement with all those stringent criteria, the alternative is time studies of 2 weeks per quarter. Now again, there's no pre-approval requirement. All those other selection of the week requirements are not required. But 2 weeks per quarter is the general standard for that. There's no pre-approval. Key thing there. Furthermore, the time studies, this is an absolute rule, really with any documentation. The time studies must be contemporaneous, and they must be signed by that physician. The physician has to agree that, yes, this is what I spent my time on. So they have to be contemporaneous. We're not going to allow somebody's recollection a year and a half after the fact as to what they did in a particular week. That makes no sense that would be any level of accurate. Now, the other thing about this that has come up is that no estimates of time reported on time study may be allowed. In other words, you're already using an estimate of the entire year. You're selecting a couple weeks each quarter to estimate how much time you would normally spend in an entire year. CMS does not allow an estimate within an estimate. So in other words, you can't just estimate, hey, on this day, well, I think I'm going to spend about this much time doing this service, this much time doing this service. It has to be exact time. So, when did you start performing that particular service? When did you end at that time? And it has to be sufficiently broken out into various time categories. Similar to what was on the allocation agreement, but possibly even more detailed than that, depending on what types of activities. It has to be detailed enough so we can clearly identify whether a particular service was provider component, professional component, or not allowable at all. Now, if no time studies are available to support the allocation agreement, if no time studies or other documentation, ongoing time report, whatever, if nothing is allowable, or if nothing is available, then that cost may be disallowed, which means it'll be adjusted 100% to professional component because we have no documentation supporting that anything was provider component. There is an alternative available in the ER only, and this relates to the use of the emergency room patient logs. Now, the idea here is that instead of essentially disallowing the entire cost due to lack of documentation, we can use this documentation that is going to be pretty conservative, but again, it's better than 100% disallowance. So the idea here is that we have a time card or a schedule that can support the physician's total time. They have to maintain documentation of how many hours they were on site, period. So the idea is that we need to be able to identify what portion of time is professional component. Since we can't identify for sure what's provider component, we at least need to be able to identify what's professional component so we can carve it out. So if an ER log exists showing when the patients were signed into and out of the emergency room, this time, because it's documented, can be used as an assumption of physician face-to-face time. And again, that assumption is extremely conservative because generally a physician is not spending 100% of the time that the patient's in the ER. In other words, a patient is not going to see a physician 100% of the time that they're in the ER. However, this is being used to avoid the 100% assumption of the professional component. Again, it's absent evidence to the contrary, but in this case, by the time we get here, there is no evidence to the contrary. That's why we're using this as an alternative. So the patient's time in the ER, from the time they were signed in to when they were signed out, That will be used to determine the professional component, and then any time that's left where there were no patients in the ER, that can be left as provider component. Again, that's certainly not the best approach, but it's better than having 100% disallowed due to complete lack of documentation. And the other situation I'll bring up that has come up a few times over the years would be the RFID badge systems. And these systems come up where a physician wears a badge and they either scan into certain rooms, or the badges, the system can determine the proximity to those certain areas or certain rooms. The system has to be set up so that certain areas or rooms are assigned as patient care, which is professional component, and other areas are assigned as provider component or general services, not face-to-face patient time. Now, this is fine overall, but the systems have to be set up properly, and there have to be sufficient controls in place to ensure their accuracy, and obviously the physicians have to be wearing the badges and using them properly. So when we're asked the question as to whether these are allowable, the answer is that yes, generally this would be considered allowable. However, it's all subject to audit based on your controls that you have in place. Because if there are insufficient controls in place, then we can't rely on that documentation. So that's the key thing there. It's always going to be subject to audit. Now let's take a look at A82 again. And we saw an example of this earlier, but basically if your A82, if what you have split, so how you've split the total remuneration into professional component and provider component, if that does not match the allocation agreement or the time studies, then that's going to be adjusted at the time of audit. Now, column 3 is total remuneration, we said. It's a portion amount reported on worksheet A. Column 4 is the professional component. Column 5 is the provider component. The thing to understand here is that column 4 and 5 don't necessarily need to add up to column 3. They can never be above it. They can never exceed column 3, but they can be less than column 3. There might be some costs that are, yes, they're total remuneration, but they're not really either professional or provider component. They're not allowable. So those could be the difference between column 4 plus column 5 versus column 3. So obviously the total has to be at least equal to the two components, or you'll get a level 1 edit on the cost report. However, the cost reporting instructions are actually incorrect. They say that the non-allowable services must not be included in either column 4 or column 5, which that part's correct, but the last part is incorrect. It says the instructions for column 18 ensures that the compensation for non-allowable services included in column 3 is correctly eliminated on worksheet A8. That's actually not the case. The only automatic adjustment that's made is to adjust out the column 4 professional component. That's automatically carved out of the cost report. But if there's something that's not allowable for a different reason, that has to be separately adjusted on worksheet A8. So again, if there are non-allowable costs, you have to go directly to A8 and make the adjustment rather than doing it on A82. We talked earlier about how columns 6 through 18, or 6 through 17 actually deal with the RCE limits that are applicable to acute care hospitals. We're not discussing that in this training, but that's what those columns would be for. And finally, we get to the last section where we're just talking about the risk areas that we're looking at from the audit perspective. We're going to be reviewing total compensation to make sure it includes everything that was allowable. And if it does include non-allowable, that's fine for total compensation, but we need to be aware of what it was so it can be separately carved out in worksheet A8 as a separate adjustment. We would want to be aware of whether there are special costs included in total compensation. So, for example, the availability or on call. Are those costs included there? Do they meet the certain criteria for the allowability? The big portion of the review is going to be related to the allocation, making sure the time studies exist, the allocation agreement existed, or if the ER logs are used to support the allocation agreement, whatever the case may be. We're going to look at how it's reported on the cost report, and again, ultimately, that documentation. So from an audit perspective, these are the things we're looking at. I hope this video has helped you from the provider perspective to understand how that worksheet A82 flows, what documentation is required, and how we as auditors from the MAC are going to be reviewing this. So I thank you for your time, and I look forward to talking to you in the next video. Have a great day.